Ladies and gentlemen, good morning. It's my pleasure to welcome you on behalf of WHO, Dr. Luis Sambo and myself to this two-day consultative meeting on a very specific as well as very critical subject. Originally and until yesterday, my plan was to arrive at Tunis yesterday evening to participate fully in this meeting. But unfortunately, due to unforeseen circumstances, I was forced to interrupt my travel today and head back to my office in Cairo. I very much regret not being able to join you today and tomorrow, but I hope to be in touch with my colleagues and try to follow up the progress of your work over the coming 2 days. Both Dr. Sambo and I, during our discussions with many of you, have become more and more convinced that the setbacks in achieving the global eradication of polio and increased coverage with routine immunization require special focus in our two regions. As you know, the three main countries in which indigenous wild polio virus is still circulating, Afghanistan, Nigeria, and Pakistan, are within our two regions. Other countries where the immunization programs are not on a strong footing and where insecurity and other complex circumstances are major factors also face issues that are hindering the global eradication of polio efforts and impeding scaling up of efforts to reduce child mortality in high-burden countries. Fortunately, the intensified effort to improve both the quality and coverage of polio eradication activities has yielded positive results. Both the intensity and geographical scope of poliovirus transmission have diminished. And in 2013, among the endemic countries, Afghanistan and Nigeria registered a 40% decline in confirmed polio cases compared to the same period in 2012. So this is positive progress. However, endemic transmission in both Nigeria and Pakistan still exists and is mainly in areas with significant insecurity associated with the killing of vaccinators and/or bans on vaccination by local leaders. In 2013, all transmission in Afghanistan was genetically linked to ongoing endemic transmission in neighboring Pakistan. Outside these countries, the remaining areas of endemic transmission are also characterized by insufficient community demand for polio vaccine, specifically, and other routine vaccines in general. These areas face significant challenges with regard to health infrastructure and access to people, many of whom live in difficult terrain. In April 2013, wild poliovirus from northern Nigeria was imported into Somalia, and this resulted in an explosive outbreak that has now affected 3 countries in the Horn of Africa and resulted in over 200 children being paralyzed. 193 cases in Somalia, 14 cases in Kenya, and 9 cases in Ethiopia. Neighboring countries in both regions are also at risk. Polio cases were similarly reported in Syria, and furthermore, at least 6 neighboring countries and areas are currently at enormous risk. These are Lebanon, Jordan, Iraq, Egypt, occupied Palestinian territory, and Turkey. It is important to note that all the infected areas are characterized by high levels of insecurity, difficult terrain, poor health infrastructure, and inadequate coverage. And at present, the bulk of cases is occurring in south-central Somalia and the federally administered tribal areas in Pakistan, where polio eradication campaigns could not be conducted because of bans, insecurity, poor management of vaccination activities, as well as misconceptions about immunization. The current insecurity in South Sudan and Central African Republic enhances the risk of poliovirus importation in these areas from nearby countries, that is, from the Horn of Africa and from Cameroon, respectively. Colleagues, I wish to draw your attention to the polio eradication and endgame strategic plan 2013 to 2018, which all member states are committed to implement. One of the 4 objectives of the plan is to strengthen routine immunization. There can be no doubt that achieving polio eradication without strengthening the immunization systems, especially in countries facing insecurity and other humanitarian circumstances, will be extremely difficult. And as you know, the member states, together with WHO, UNICEF, and other key partners, have developed a global vaccine action plan. This was unanimously endorsed by WHO's member states in May 2012 and is a roadmap to prevent millions of deaths by 2020 through more equitable access to existing vaccines for people in all communities. The implementation of the plan has a pivotal role to play in helping to achieve the goal of global polio eradication. In my own region, the estimate for DPT-3 coverage in 2012 was 83%. Despite this apparently reasonable achievement, 3 million children in the region remain unvaccinated, and more than 90% of these are from countries with insecurity and or other complex emergencies. In 2013, more than 35,000 suspected measles cases were reported, of which over 13,000 were laboratory confirmed. So a lot, therefore, needs to be done in countries showing a high burden of measles and low routine immunization coverage. And as you know, countries in both regions have identified and implemented a number of innovative strategies aimed at achieving both high coverage through supplementary immunization activities and higher demand for immunization in these areas with insecurity and other complex crises. These innovative tools and strategies include combining polio and measles supplementary immunization activities, extensive cross-border coordination, the use of permanent polio vaccination teams, deployment of transit teams at border areas, the use of short-interval additional dose strategy, low-profile vaccination activities, and ensuring timely support with human resources. These have been useful in raising the population immunity, while the AFP surveillance sensitivity has been increased through active visits, collecting samples from contacts, and initiating environmental surveillance. And in this regard, let me highlight an area of work that I think requires a higher level of attention and innovative approaches, and that is communication and community mobilization. Communication interventions to enhance community demand for polio and other vaccines are key. These include increased involvement of influential local religious and traditional leaders, deployment of polio plus packages, and engagement of a broad range of interpersonal communication channels. And here we need to be creative, and we need to think outside of the box. The majority of the polio cases are reported from Islamic countries and populations. In the current environment of fear and confusion, the Islamic community needs visible solidarity. Only 3 weeks ago, we were in Jeddah, attending the first formal meeting of the Global Islamic Advisory Group. The meeting was successful in achieving its aims, which were to review the situation and to find solutions to help these countries and populations. But more needs to be done, and the recommendations of the meeting have to be actively followed up. Islamic scholars, politicians, and community leaders need to speak with one voice to address misconceptions and to counter false propaganda and disinformation. So let me now conclude. You have all come here today with extensive knowledge and experience working in such challenging situations. This consultation will provide a great opportunity for experience to be shared both within each region and across the two regions. I would encourage you in reviewing where we are now to be constructively critical and to be innovative in coming up with new ideas on the way forward. With the goal of global polio eradication already significantly delayed, the eyes of the world are set on our two regions. I'm sure the outcome of your deliberations will help us in achieving our goal of global polio eradication. I wish you a very successful meeting. Thank you.